laying in the backyard and using baby oil. I mean, there was no sunscreen. We didn't have to do any of that stuff back then.
Coming up today, it was a different time back then. Erin Kinsley never thought about the risks of having fun in the sun. But decades later, a devastating diagnosis forced her to see the sun and her health in a very different light. Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. Tanning beds and baby oil. For many of us, those were the good old days of having fun in the sun, long before we really understood the risks. Today, we are sharing Erin Kinsley's story, how a mole that she ignored and quick action by her team of doctors made all the difference.
Erin Kinsley remembers the so-called good old days of the 80s.
Tanning beds, and I went all the time. And back then, you didn't have to get permission from your parents.
When the sun was your BFF.
Or laying in the backyard and using baby oil. I mean, there was no sunscreen. We didn't have to do any of that stuff back then.
Fast forward a few decades, and Erin discovered those carefree days in the sun had finally caught up with her.
It was a mole, probably since I was a teenager, that I had. Never thought about it. And then probably early 2022, it started growing, and it was kind of itching, took on its own little identity.
It was her husband who urged her to get to the doctor, especially knowing her family history.
My dad passed of cancer at 39, and so it wasn't melanoma or anything, it was lung cancer. But in my mind, I was, you're already scared about it.
Her fears were confirmed. It was melanoma, a serious type of skin cancer.
I had to leave work. I mean, in my mind, I'm done. I mean, I called my mom crying, I called my daughter crying, I called my husband crying.
She was referred to the University of Kansas Cancer Center, where her surgeon, Dr. Luke Selby, immediately removed the tumor.
My surgeon told me melanoma does what melanoma wants to do when melanoma wants to do it. And so I don't know how long, it could have been there.
Next, Erin started 18 rounds of immunotherapy, a type of treatment that helps your own immune system recognize and attack the cancer cells. She will continue with maintenance medication and have follow-up scans indefinitely.
I have to wear sunscreen every day, and they don't want me out in the sun for extended periods of time. Like, I can go out for 5 or 10 minutes here and there, but I can't be out in the sun, so self-tanner it is. I'm okay with that.
And she's okay looking at life a little differently now.
I'm just trying to get up every morning and be grateful. I know that sounds so cliche because everybody says, oh, I've got this second chance, but I really do. I mean, I've always had a lot of faith, but now I have even more because I just don't think that if it hadn't been for, oh, I don't want to cry. I just felt so grateful to God and to my doctors because I just felt like there's no reason that as long as that thing was back there and as long as I put off going and getting it looked at, that I should be in the shape I am right now. I'm grateful every day. I just that I get to wake up and I get to go to work and, I get to bicker with my husband.
And we are so glad to have Erin Kinsley joining us this morning here in studio. How are you doing today?
I'm okay.
Good, good. I know those are happy tears to be here surrounded by your medical doctors, medical oncologist Dr. Gary Doolittle next to me, and across from me, surgical oncologist Dr. Luke Selby. So glad to have you both here, and I know you're so glad to see Erin doing well.
Always.
It's all right. So, Erin, take us back to when you first noticed that mole.
Oh, it had been there. It had just been there. I would say though, it started changing and it started growing. It was itching and changed color a little bit. And I never really thought, I thought maybe it's just, I'm getting older, it's just age.
We got your little tissue coming in
here.
Thank you.
And I thought, I didn't think a whole lot of it. It's just, I'm, getting older and, I'm thinking things are changing. But then when it started actually growing, then I was like, okay, there's something wrong here. And my husband said, no, you're not waiting anymore. We're going to get this checked. So that's kind of where that went.
That's a good hubby. He's got
Yeah,
your back.
very much, literally.
Literally had your back. Dr. Doolittle, that sounds familiar, what you've said. Itchy, changing, red, all of those things. When someone presents with a changing mole like Erin's, what are those red flags that concern you the most? I would imagine that someone isn't getting it checked out.
Right. So if a mole is changing in any way, size, color, if there's any symptom, itching or bleeding, I think Erin's situation isn't so rare in that 20 to 30% of melanomas present in a mole that's been there for decades. And so the natural response from the patient is, I've had this most of my life, this can't be cancer. But what Erin clued in on was so important, it was changing. It looked different. Moles that are greater than 6 millimeters in diameter, which is about the size of a head on an eraser, on a pencil rather. If it's bigger than that, then those are all kind of signs that it should be checked out. And then in the end, if there's any question at all, just point it out to your primary care practitioner or dermatologist and get it checked out. If you have any question in your mind that there's a change, get it checked.
We know melanoma is aggressive, but when we say aggressive, compare that to other skin cancers.
Yeah, I mean, the more common skin cancers, first basal cell carcinoma, and then secondly squamous cell carcinoma, make up the vast majority of skin cancers. It's malignant melanoma and Merkel cell carcinoma, or skin cancers that are more deadly. And what makes them more deadly is their ability to spread from the primary site. So that area on Erin's back, it can spread to a regional lymph node, it can spread to almost anywhere in the body. I love your quote, melanoma does what it does, because that's very true. It's the only thing predictable about melanoma, and talk about cliches, is that it's unpredictable.
Yeah.
Right?
What do you mean it does what it does?
So, we're much better at understanding how to treat melanoma than we were when I started my training, or honestly, than when I started my practice here. And we understand a lot more about it, but just like anything, as we learn one or two more facts, we realize we have this one new bit of knowledge and 3 more questions. So, if Erin had come to our office 10 years ago or 20 years ago, our ability to predict how it was going to behave and treat it was way different. But we still, I leave clinic every week realizing I don't know as much as I wish I knew.
Erin, when you heard melanoma, what were you thinking?
It was scary. And I don't know if it was just the word melanoma or if it's the fact that I knew that wasn't a basic, let's go in and just scrape it off, get it removed, cancer. And I knew that I have a family history. It wasn't just my dad, it was my uncles, my grandfather. They all died of cancer. And so in my mind, it was almost, is this a death sentence? Am I already done? And so it was just scary. I mean, I was just scared. And I think that's probably why I put off getting it checked as long as I did, because I should have done it sooner. And I hope other people will do it sooner. If you think you might need to have it checked, because I didn't. And who knows, I might not have even have done what gone as much as I have.
Well, that's why we're so glad you're here, sharing your story with us. Dr. Selby, you removed the tumor and then several lymph nodes. Why is lymph node evaluation so important when it comes to melanoma?
Yeah, so the 2 most important things about melanoma that help me and Dr. Doolittle decide what we're going to do are the depth of the melanoma on the original biopsy, that we know by the time they come and see me, and then whether the melanomas spread to the lymph nodes. And often we don't know that until after I've done surgery. So I have rules that I follow on when I care about looking in the lymph nodes. And we do that with a procedure that's called a sentinel lymph node biopsy, where we inject some dye. The dye doesn't go to melanoma, it just goes to lymph nodes. But lymph node drainage is very predictable. So if you inject the dye around the melanoma, the dye is going to go to the lymph nodes that drain that part of the skin, which are the lymph nodes that would have the melanoma if the melanoma has traveled. Then go take out the lymph nodes that have the dye. Then our expert dermatopathologists look at it, and then I know if I need to get Dr. Doolittle or Dr. Nina Matthew, who's our other melanoma medical oncology specialist, involved.
So how do you decide when surgery is the best option, or is it always the route when you're talking about melanoma?
Several years ago, the answer would have been always surgery first. Now, the more we learn about immunotherapy, which was the class of medication that Erin was on after surgery, there are some instances where we're actually starting with immunotherapy and giving a couple doses of immunotherapy, followed by surgery, followed by more immunotherapy. That gets into a conversation that the surgical oncologists and the medical oncologists have to figure out for this particular patient what's the best recipe of immunotherapy and what's the best order of surgery first, followed by immunotherapy, or a little bit of immunotherapy first, followed by surgery.
Erin, you talked about your husband Scott pushing you to get checked. He'd been following that mole and watching you. I mean, it's just so important. I mean, your partner, you know, standing in the bathroom with you every day, watching and checking and seeing, literally having your back and watching that grow through the years. How important was that, and his urging you to get that checked out?
Very, and even at a point where I would say, oh, it's fine, because I didn't want to deal with the fact that it could be bad. There came a point where he finally just said, I called, I made an appointment, you're going to the dermatologist, we're having this removed, and either you can tell your boss you won't be there tomorrow, or I'll call your boss and tell him you won't be there tomorrow. And I worked for wonderful people who said, please go, you know. And so that's what started it. So yeah, I owe it all to him.
Those are the kind of, Dr. Doolittle, those are the kind of spouses and partners and family members you've got to have on your side, right?
Absolutely, absolutely. Because the fact is, as you said, it's on your back. You can't check your own back, right? So part of it is, you know, being vigilant for yourself individually. Part of it's eliciting help from family members, but also really pointing it out to your primary care practitioner if there's a mole that's changing, or I want a skin check. You know, I haven't had a skin check. I've had a history of a lot of sun exposure, because a lot of times that primary care practitioner has a limited amount of time to spend with you, and if you need to push them a little bit, and they'll be very willing to, but nudge them a little bit. I want a total body skin check.
Erin, walk us through your treatment and path during this time for you.
Well, it was, I came in, and I think it was within, 6 days? I think they had me, I was in surgery within 6 days. It was outpatient. And then after that, you know, I don't even know how, by the grace of God, there was no melanoma in the lymph nodes. So that was very good. But it's still not knowing exactly where it could have gone or how it could have spread. We decided with the doctors, we decided on 18 rounds of Keytruda, which it didn't have the effect on me, thankfully, that a lot of chemotherapy has on patients. Didn't lose my hair, wasn't sick. I was very tired. That's about the biggest side effect I had at the time. The only other side effect is Keytruda did take out my adrenal gland, so I just have to take hydrocortisone to replace the cortisol that I don't have. Other than that, as far as treatment, you know, I would go in on a Friday and I could go back to work on Monday. I would sleep all weekend and go back to work on Monday. So it really, as far as taxing on the body, was a lot less stressful on the body. I think, I mean, I've seen what chemo does to family members and friends, so it didn't have any of those effects on me. Thankfully, I didn't have that.
Well, through it all, you got to participate in something pretty fun. You were chosen to participate in the NFL's Crucial Catch. It's the annual NFL initiative for the prevention and early detection of 7 preventable cancers. Those include breast, prostate, cervical, childhood, colon, lung, and of course skin that we are talking about here this morning. Tell us about what that experience meant for you at that time.
That was, I mean, it was great. I got the call that I was chosen to go and represent the skin cancer. Went with my nurse practitioner, Kristen, and we first went to a luncheon at the Chiefs' new training facility, which was great. We got to see some of the players. They were actually getting ready to go out and practice while we were there, so there was a little bit of photo op. They came in, got their lunch, kind of looked at us, and went back out. But a lot of them stuck around, took pictures. Casey Wolf, Mark Donovan was there. And Coach Reed came through, and we got to talk to him a little bit. And then we got to sit and watch practice. And then while we were there, they gave us all, told us we were all going to be getting tickets to the Crucial Catch game, which was against the Detroit Lions. which was one of the few games we won this year, which was fantastic.
Nice.
But yeah, my husband went with me to the luncheon, and then my daughter called dibs on the football ticket on the game. So
nice. Nice.
Yeah.
Well, so
it
glad
was
and
good.
well deserved. I'm so glad you got to be spoiled in that way.
Yeah.
Well, be sure to ask your questions. Use the chat on YouTube or Facebook. You can email the Medical News Network. That information is there on your screen. I want to get to a little conversation we were having right before we went on this morning, because when the three of us get together, us fair-skinned, blue-eyed people get together, the three of us always have these conversations about, kind of how we're protecting ourselves. I know you have your convertible, and you're always wearing your hat, and
Yep.
you do it right, and you're out doing your boat thing, and out on the lake and protecting yourself.
Cap, sun-protective clothing, sunblock.
But tell us what you said and what we were trying, this kind of phenomenon that we were trying to figure out a little bit before we went on today.
Part of what's really been challenging for me personally, because you can't tell now, but I grew up with bright red hair and I have very fair skin. And really culturally, what is considered most attractive is dark hair, dark eyes, dark skin. And even my daughter, who's very redheaded, she wanted a tan because that's considered attractive, and it just wasn't in the genetic cards for her, right? I think what I've always struggled with is, how did we get to this place where being tan is the sign of beauty and having fair skin, notice I didn't say pale, I said fair skin, is not, or is less attractive. And culturally, how do we work at that? And particularly for, I think, teenage girls, our biggest risk years are between 15 and 25 for sun exposure that causes blistering sunburns. And so it's that group that we really need to get to say, look, you're fair and you're really attractive, just the way you are, right? And that's a challenge for us, I think.
Selby, what do you make of it?
Yeah, so I think the point to make for patients who either from their parents inherited this complexion and this hairstyle, who are at high risk of developing melanoma, or patients who have had melanoma, like, we can't go out in the sun all day not wearing sunscreen, but I mean, you alluded to it, I have this hairstyle and this complexion, and I drive around in a convertible where when it's nice out, the top is down, but I have a hat, a wide brim hat in my car, I have SPF 30 sunscreen in my car, I torture my kids. They play, like all kids growing up, they play 27 different sports, and they have a little bag for every sport, and that bag has their water bottle and their shoes and their sunscreen. And so, what we talk to our patients is SPF 30 or greater applied in the morning and then reapplied every 2 hours. So when you're sitting at the pool and you realize you're hungry, you realize you're thirsty, you also probably need to reapply your sunscreen, and it's just developing that habit more and more as you pay attention to it and you see at the pool, like, people are coming and they're hanging out at the pool, or they're hanging out at the tennis court, they're hanging out at the golf course, whatever it is that they're doing. But you see more people applying sunscreen. Now, what we got to get to Dr. Doolittle's point, we got to get to teenagers. The problem is the ages of 15 to 25 are when you're most susceptible to UV damage with lifelong risks. It's also when you're least susceptible to doing what your parents tell you. And it's education. The Masonic Cancer Alliance, which Dr. Doolittle helps run here at KU, has a pool outreach initiative to try and get sunscreen and education to just keep reminding people, so you can go out, you can hang out. It's nice being outside in the summer. It's like the whole point,
tough.
right? But you just got to do it safely, right? Driving is fun. We wear seatbelts. Riding a bike is fun. We wear helmets. Yeah. Being outside is fun. We wear sunscreen.
Yeah, and Erin, you mentioned it because it's a thing that you said you're going to start wearing self-tanner, but it goes back to what it's what you said, Dr. Doolittle. It's like, but it goes back to the society that we still need to feel like we want a less
this is okay
fair skin color. So, but yeah,
it's a really interesting challenge.
It is very interesting. So we go back to.
But reinforcing Dr. Selby's point, you can have fun in the sun, right? You can go to the lake, you can be outside, you can just protect yourself. Cap, sunglasses. Rash guards, oh my gosh. Go to neighborhood pools now. I bet you at least 70% of the kids have rash guards on. Long sleeve, swimwear, that protects you from the sun. And that is a huge shift in the last 20 years, and a shift in a very positive direction, I think. It's not unusual for kids to be required to put on sunblock. It's just part of the routine now. School playgrounds, part of the routine.
It's becoming, I run around and spray my kid. They run away from me, but I'm like running around with my spray bottle and try to get a few spots on them if I can, right?
Exactly.
Yeah. It's just, it's getting, you know, when you're raising kids, everything we do as parents is building good habits, right? You start reading so that just becomes a lifelong habit. You start exercising because that becomes a lifelong habit. Well, you start putting on sunscreen so that becomes a lifelong habit, so that as they're ready to fly the coop, it's become a habit.
Yeah. I want to talk about Keytruda a little bit, this immunotherapy, so very important when it came to your treatment. What kind of side effects were you monitoring with that?
Right. Well, immunotherapy, I have to repeat your comment because it was so accurate. Immunotherapy is not chemotherapy. That's the first thing I will tell a patient when they're a candidate for immunotherapy, because everyone has had a family member or a friend that's had chemotherapy and had really rough experiences with it. Immunotherapy is designed to stimulate your body's individual immune cells, activate them. The immune cells travel throughout the body, and the hope is that it will find any areas of melanoma, attach themselves, and kill the melanoma cells. But the challenge with it is those same immune cells that travel through every organ system in the body can also sometimes attack healthy tissues, and that's where the side effects come from. In Erin's case, it was the adrenal glands, where they stopped functioning because her own immune cells were fighting it and actually cause it not to function. But it could be virtually any organ system: lungs, liver, colon, GI tract, stomach, thyroid, adrenal glands. I mean, just virtually any. I think the nice part about this is we've had 15 years of immunotherapy in the clinic. Huge game changer for the treatment of widespread melanoma. And we're getting much better at managing them. We haven't gotten to the point where we can figure out who's the individual that's going to have adrenal insufficiency, but we are much better at recognizing the symptoms related to it and then treating them appropriately. So it's, 15 years ago, we had nothing to prevent a future recurrence or to treat metastatic disease. Now, even with widespread disease, 60% of patients are melanoma free at 10 years. So I mean, it's a game changer. I mean, it's just changed. Dr. Selby likes immunotherapy more than I do, and he's a surgeon.
Well, and you asked earlier how treatment has changed. When I started my practice here at KU, Erin, who, when surgery was all said and done, had a very thick melanoma that had not spread to the lymph nodes. When Dr. Doolittle and I started working together, she wouldn't have been able to get Keytruda because we didn't have the data that patient population benefited from it. So there were patients who, prior to Erin, were enrolled in clinical trials that helped. We started a clinical trial because we wondered if it would help. The patients in that clinical trial showed us it would help, and now, and honestly, probably if Erin had showed up 2 years before she did, she either would have been in the trial or wouldn't have been eligible for the treatment. And so when I was saying earlier that over the course of my career, even just as faculty at KU, things have changed, this is the perfect example. And it's the perfect example why when patients come to our clinic and we offer them enrollment in a clinical trial, A, they benefit themselves, but B, everybody coming after benefits from that very small number of people in a clinical trial.
Such a thrilling time.
It really is.
To say the least.
It really is.
Erin, how has this diagnosis just changed your life day to day? And I know you're taking this medication.
Day-to-day, it's the medication.
But what about the good stuff?
The good stuff is, I mean, I'm just in a better headspace. I mean, I have to be. You know, God knows what could have happened if we hadn't caught this when we did. We hadn't have done what we, hadn't had the surgery and the Keytruda. Just day to day, I mean, I have to be a little more careful as far as when the with the adrenal insufficiency. If I get sick, I have to take extra meds. I mean, that's basically it. If I get sick, stress, it's called stress dosing. I have to take extra it's just hydrocortisone. So I have to take extra steroids. But as far as my day-to-day, I can go and I do everything I've done. You know, I'm 56 years old. I can do everything that I've done my whole life, and so it's been I don't have any. There's no limitations. I don't have anything that I can't do. Can't go out in the sun without sunscreen. I mean, that's about what I can.
That's it.
But you can go out.
But I wasn't supposed to do that to begin with. So.
Good answer. Okay, I'm glad you got that in there. Let's get to some questions from our viewers this morning. Jeremy says, is it typical that melanoma starts with a mole, or can it pop up anywhere?
Right, that's a good question. I mean, 20 to 30% of patients that are diagnosed with melanoma, it comes from a mole that they've noticed previously sometimes for years. The majority of melanomas actually come with a new mole that is recognized and biopsied and found to be malignant. But part of the challenge is if you've had this mole since you were a kid and it's changing, you don't think that necessarily is a problem because you've had it all your life. Well, no, any skin spot that changes, grows, itches, bleeds, anything that looks different, if you even think it looks different, boy, point it out to your primary care practitioner.
All right, another question. Can you get skin cancer on your lips, and what does that look like?
Yeah, you can. So most melanoma comes from our skin, but you can get melanoma from, honestly, any surface of the body. You can get it on the lips. The same rules apply, and you can get non-melanoma skin cancers on your lips, on any surface of your body. So the same rules apply when you're sitting there brushing your teeth in the morning and you're like staring off into the mirror, not really paying attention to anything, and you notice the spot on your lip looks a little weird. Think about it. If the next day you really do think it looks a little weird, looks a little different, get into your primary care doc, get into your dermatologist, and go from there.
Janine wants to know, did both of the doctors protect their skin when they were young before we knew this much about skin cancer and before you got into this specialty?
Not as much as I wish I had. My children wear more sunscreen than I did.
Well, that's a luxury because when I was young, there was no sunscreen. So that's true. That's the truth, though. But what I wanted to avoid was sunburns. So I wore a T-shirt, and we did have zinc oxide. So I was the kid with the white stuff on his nose at the pool. But it was easier for me in some ways because I didn't want the pain of a sunburn. Yeah. So I would avoid it and do things to try not to get burned.
I have a question.
Yeah.
I'm obsessed with trying different types of self-tanners. I don't know if you are, Erin, as well, but I'm constantly trying to, because I don't like to get tan in the sun, but I do like to have color. Are those safe to be putting on your body, or just safer than sun exposure?
You know, personally, I don't know the answer to that. We get asked a lot a sort of different question, which is what's the best sunscreen to wear?
Okay.
And the answer that I give my patients is the best sunscreen to wear is 30 or greater that you're actually going to put on. So nobody knows what the best sunscreen is, but imagine a circumstance where we do. If you put that on and you don't like how it makes your skin feel, you're not going to wear it. So the best sunscreen is the one that you're going to put on that doesn't make you feel too whatever it is that is going to keep you from putting on.
Great.
In terms of the self-tanners, I don't know the answer to that.
Okay. I will chat GPT that later.
But look at the result critically when you do,
Yeah.
Jessica.
I promise I will do my research. I promise. I will look at the studies, I promise. Dr. Selby, what's the big takeaway today?
So one big takeaway is that we all grew up not wearing as much sunscreen as we now realize we should have. And when patients like Erin notice that a mole's changing, there's a lot of fear, there's a lot of regret, there's this voice in the back of your head blaming you for things. I tell my patients all the time, I remember a sunburn that I got when I was in college. I was out all day, not wearing a shirt, just like my back peeled so bad that I couldn't sleep because I couldn't lay down comfortably. And it happens to everyone. It's not something to be embarrassed about. When you come and see me in clinic or you come and see Dr. Doolittle in clinic, we ask about your sunburns, but I don't then, get all judgy about what happened. because like we want to help you get better. What's done is done. I don't have a time machine. I can't go back and give you sunscreen the morning of that sunburn. And so if you're nervous, bring it up to somebody. And then if you find out you have melanoma, come and see us and we'll talk to you about what we got to do and we'll get you through it.
Erin, thank you so much for sharing your story, because
Thank
your
you.
story is not unlike a lot of us who
Right.
grew up in the 80s and spent
beds.
way too much time out in the sun. So what do you really want, what do you want people to take away from your story?
I'm just going to reinforce, if you have a spot that you think you might need to have it checked, have it checked. It doesn't matter how small it is. I had one removed from my back last week, my dermatologist did. It was no bigger than the end of a ballpoint pen. And it was fine. It was fine. But you know, if you think you might remotely need to have it checked, have it checked. Let me be the PSA, and don't do what I did. Don't. It's very scary, very scary.
Well, thank you for being here, and we
Thank you
are
for
glad
having
you
me.
are here. So thank you
Thank
so
you.
much. Dr. Doolittle, wrap us up. What's the big takeaway?
I think the big takeaway is there have been huge advances in the last 15 years, and melanoma isn't necessarily a death sentence. And when you get this diagnosis, I have to admit there's a lot of tough, bad information out there that hasn't really caught up with some of the advances that we've seen in the clinic. So it's not an automatic death sentence. Get in and get it checked, because we have the whole landscape for the treatment of melanoma has changed remarkably in the last 15 years.
Well, thank you to all of our guests for being here with us today. Thanks to our viewers for being here with us. We will see you back here tomorrow. And coming up tomorrow on All Things Brain Health, cutting back on alcohol. It's gaining popularity from dry January to a rise in mocktails. Is it a health trend or an overall push to a healthier brain? How alcohol impacts your risk of memory loss.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.